Hello and welcome again to the continuation of the 5th Pancreas Cancer Academy organized by the Central European Cooperative Oncology Group. I want to thank the faculty which participates in this 5th Pancreas Cancer Academy. I want to thank Xavier for supporting it and thank Gerald Prager for organizing the faculty and coordinating the news that are being brought to you. I wish you very interesting hours with the continuation of the Pancreas Cancer Academy, and I do hope that we will see each other in person in the very near future to celebrate the 6th Pancreas Cancer Academy. Thank you very much and all the best.
Hello, my name is Gerald Prager. I'm working at the Medical University in Vienna, and today it's a big honor and pleasure to have the highly sophisticated, very well-known experts here at this Pancreatic Academy Symposium. First, Dr. Golan will give an overview about the most important abstracts of the ASCO 2021 meetings in respect of pancreatic cancer. And then we have the pleasure to discuss this abstract with Professor von Kooczen from Belgium and Professor YOO from South Korea, and how we can translate the recent findings into the clinical practice and what questions are still open to answer before we can translate new findings into our daily clinical routine. But first of all, as I mentioned, Dr. Golan, she is a professor at the Sheba Medical Center in Tel Hashomer in Israel. She is leading their clinical phase 1 unit. You might know her as the first author and principal investigator of the POLO trial, which recently has demonstrated that in the Prager germline mutated pancreatic cancer patients, PARP inhibitors like olaparib is now a new standard of treatment after an induction treatment with statins. So now, Dr. Golan, the floor is yours. We are very happy and excited to hear about the most important abstracts in pancreatic cancer from the recent ASCO 2021 meeting.
Hi, my name's Talia Golan. I'm a medical oncologist from the Sheba Medical Center at Israel, and I would like to give an ASCO 2021 update on pancreatic ductal adenocarcinoma. This is for the CSOG Pancreatic Cancer Seminar. These are my disclosures. So let's start with NRG1 fusions in pancreatic cancer. NRG1 is one of the 4 proteins in the neuroregulin family that act on the EGFR family of receptors. Specifically, NRG1 binds to HER3, promoting HER2-HER3 heterodimerization and activation of the PI3-AKT-mTOR pathway signaling. The prevalence of NRG1 fusion is very low in cancer, and the prevalence specifically in pancreatic cancer is 0.5%. However, if you're looking younger patients or patients who are KRAS wild type, the prevalence is slightly higher. Zenocutuzumab is a novel antibody that docks onto HER2 and blocks NRG1 interaction with HER3. In the study, 12 patients with pancreatic ductal adenocarcinoma were identified and enrolled with an NRG1 fusion, 25 patients with non-small cell lung cancer, and 10 with other diseases. In this slide, you can see the response rate in the 12 patients with pancreatic cancer and NRG1 fusions. You can see 5 had confirmed partial response, 6 had stable disease, and 1 patient had progressive disease. All patients received PRs at first tumor assessment, and all PRs were also confirmed at 2 tumor assessments more than 4 weeks apart. And this is a nice illustration of a patient, a 59-year-old male who has liver metastases, as you can see in his baseline CT. He had previously received 2 lines of chemotherapy, FOLFIRINOX first line and gemcitabine second line, and this was his Zeno was his 3rd line treatment. And there's a nice reduction in tumor liver metastases and in CA99 levels. The authors that was zenocutuzumab is highly effective in pre-treated patients with pancreatic cancer and NRG1 fusions. And this is an interesting first-of-concept study that antibody-based therapy can actually target a fusion oncoprotein. The next abstract I'd like to discuss is masitinib plus gemcitabine as first-line treatment of pancreatic cancer with pain. This is a phase 3 study. So masitinib is a small molecule targeting mast cells and macrophage activity. These are innate immune cells that seem to be a critical component of the tumor microenvironment. A proof of concept study was done in when masitinib was given in combination with gemcitabine in patients with pancreatic cancer, and only in patients with pain and overall survival was seen. So the presence of pain in pancreatic cancer is thought to potentially identify patients whose disease may be driven in part by some pro-tumoral immune effect. And therefore, in the inclusion criteria, patients had to have pain in order to be eligible for the study. 383 patients were enrolled into the study. 92 of them had locally advanced disease, and the rest had metastatic disease. And these patients were randomized in a 2-to-1 fashion to masitinib plus gemcitabine or placebo plus gemcitabine. The overall survival of the whole group was detrimental in the group of patients who received masitinib plus gemcitabine. It was 6.9 months versus 8 months for the patients with gemcitabine and placebo. However, in the subgroup of patients with locally advanced disease and pain, there was a superior overall survival of 13 months versus 11.2 months with a significant p-value. The authors' conclusions were that in patients with locally advanced pancreatic cancer and pain, this may become a new treatment option. However, the critique on the study is that the majority of the patients were around 60, 65 years of age and of good performance status, and perhaps to not be the preferred treatment option for these patients. So it would be interesting to maybe consider testing masitinib in a more maybe combination chemotherapy in patients with locally advanced pancreatic cancer and pain. Furthermore, it's not quite clear why there's a discrepancy between the results in patients with metastatic disease versus those with locally advanced. The next abstract I would like to discuss is gemcitabine and nab-paclitaxel as a backbone chemotherapy with an immunotherapy combination. So this is this study was a 3-arm study in patients with metastatic disease who were randomized to 3 study arms: gem-nab-paclitaxel with nivolumab, or gem-nab-paclitaxel with a CD40 agonist, or gem-nab-paclitaxel with the nivolumab and a CD40 agonist. In the study, the primary endpoint, which was a first-year overall survival of more than 35%, was only met in the arm combining gem-nab-paclitaxel with either nivolumab or CD40 agonist. However, the combination of the two was not beneficial. Interestingly, if you look at the higher baseline CXCR5 effector memory CD4 cells, when it was elevated, there was a superior survival in the gem-nab-paclitaxel-nivo arm. However, a lower survival in the gem-nab-paclitaxel CD40 agonist. So once again, it's not quite clear how these exploratory biomarkers and how they affect maybe the different patient populations and how this may affect determining which patient population should receive a certain arm, and additional biomarker analysis need to be made in order to understand and inform patient subset selection better. The next abstract I would like to discuss is a phase 3 trial to assess the efficacy of GV1001, a peptide vaccine with gemcitabine and capecitabine for previously untreated eotaxin-high pancreatic cancer patients. So in a previous, the Telovac study, in which GV1001 was given with gemcitabine and capecitabine, there was no increased survival. However, cytokine examination suggested that high serum eotaxin levels may predict for improved survival in patients who had received the vaccine. Therefore, this phase 3 trial was designed to assess the efficacy of JV1001 with gemcitabine and capecitabine for previously untreated eotoxin-high Korean patients with advanced cancer. In this study, which the design is a little bit confusing, 148 were enrolled, 111 of them had eotaxin high, and they were randomized in a 2-to-1 fashion to GV1001 peptide vaccine with GCSF and chemotherapy GemCap. And the patients with eotaxin low, they were only enrolled to the control group. In other words, only to receive gem and capecitabine. If one looks at the outcome analysis, so median overall survival was 11.3 months in favor for the experimental arm with the peptide versus the control arm with the 7.5 median overall survival. However, if one looks at the subgroup overall analysis according to eotoxin level, the benefit seen of the JV1001 peptide vaccine in combination with chemotherapy was only seen in patients with eotoxin high in comparison to the eotoxin low. In other words, if you look at the patients with the red in the control group, which were control but eotoxin high, the median overall survival of 11.3 months versus 8.5 months did not have statistical analysis. The critique of the study was that perhaps a different chemotherapy combination should be assessed, since the gemcitabine, capecitabine protocol is usually standard of care for adjuvant treatment and not in advanced disease. And the second suggestion was perhaps that the study should be further done only in an eotaxin high population, not involving those with a low eotoxin levels. So the next abstract I want to discuss is the long-term results of the multi-center randomized phase 3 PREOPANC study. So just to remind you all, this was a very important study performed in Netherlands at 16 centers. 246 patients were accrued. Primary endpoint was overall survival by intention to treat analysis. There were 2 arms in the study: surgery upfront followed by adjuvant gemcitabine, and a neoadjuvant approach with gemcitabine, gem radiotherapy, gem surgery followed by adjuvant gemcitabine. The patient population enrolled were patients with resectable tumors or patients with borderline resectable tumors. In the primary endpoint, overall survival by intention to treat analysis, so median overall survival was similar between patients who had upfront surgery versus neoadjuvant chemoradiotherapy. However, if one looks at the 5-year survival, upfront surgery was 6.5% versus 20% in patients who had neoadjuvant chemoradiotherapy. If one looks at the subpopulation of patients that underwent resection, so median overall survival is now significantly higher in the patients with neoadjuvant chemoradiotherapy at 34 months versus 17 months with upfront surgery. And 5-year overall percentage of 5-year survival is 8.4% in upfront surgery and 34% in patients who received the neoadjuvant approach first. In patients that started adjuvant therapy, the rate is also superior, with a 5-year survival of 10% in patients that had upfront surgery and 31% in patients who had the neoadjuvant approach. So this study seems to indicate that there's definitely a long-term survival benefit in patients who haven't approach, irrespective if they were borderline or resectable upfront. The next study I want to discuss is high CXCR4 expression in pancreatic ductal adenocarcinoma as characterized by inflammatory tumor phenotype with potential implications for immunotherapeutic approach. So we know that treatment-induced inhibition of CXCR4 and programmed cell death in the combat caused T-cell infiltration and tumor regression in a subset of patients of pancreatic cancer. So there was suggested that a phenotype may predict response, and we may be able to clinically identify those patients. And therefore, this group performed a comprehensive molecular study in pancreatic cancer evaluating CXCR4 RNA expression. So this is actually what we would call a bulk multi-omic profiling of tumor, in which all data was analyzed together. For example, a comprehensive molecular landscape involving a next-generation DNA sequencing, whole transcriptome RNA sequencing, and immunohistochemistry were performed. Quanti-sequence was used for immune cell fraction, and human protein atlas was used for analysis of CXCR4 expression. Patients were characterized according to CXCR4 expression. You can see that patients with higher CXCR4 expression had a higher prevalence of B cells, M1 and M2 macrophages, NK cells, and Treg cells. Predominantly endothelial cells and monocells were the cells that express CXCR4 expression. This was a very nice. There was a very nice discussion on the study. That this is a very nice approach. This multi-omic analysis of tumor on a very large pancreatic data set has found this interesting CXCR4 subtype of patients. However, when you look at the subtype, it includes also an inflammatory component, but there are also immunosuppressive elements like M2 and Treg. So it's unclear if the CXCR4 subtype inflammatory or have maybe more immunosuppressive elements. So in order to maybe try and discern this exact phenotype, the suggestion was to try to zoom in. So a specific analysis of single cell to identify the immune cell population, in other words, to determine the dominant subsets, and this may help understanding what the functional relevance of them are and the therapeutic implications. And now I would like to discuss several abstracts that I have gone through and find quite interesting. So this is one of the first. HENT1 gene expression as a predictor of response to gemcitabine and nab-paclitaxel in advanced pancreatic cancer. So just to remind you all that HENT1 belongs to a family of nucleoside transporters critical to entry of gemcitabine into the cells. This analysis was done on a study called the COMPASS study, which is an extensive, comprehensive genomic analysis. Patients undergo research biopsy prior to first chemotherapy and undergo whole genome sequencing and RNA-seq of this biopsy. In the study, 254 patients were enrolled. 146 of them received modified FOLFIRINOX and 104 received gem and nab-paclitaxel. If you look at gene expression levels, 133 patients had high HENT1 levels and 121 had low HENT1 levels. In regard to patients who received modified FOLFIRINOX, there was no difference in response rates or overall survival between the two groups in regard to high or low expression. However, in patients treated with a gem-based treatment, response rates were significantly higher in the HENT high patients compared to those with HENT low tumors. And median overall survival in this gemcitabine treated cohort was 9.8 months with high HENT1 levels versus 6.1 months in patients with low HENT. Another abstract discussed is the marginal diagnostic benefit of pancreatic cancer molecular profiling after a patient's already performed germline testing. So we know now that germline genetic testing is universally recommended. This is both for purposes of both familiar therapeutic guidelines, but it's not quite sure if all patients should also undergo tumor molecular profiling. So this was a retrospective analysis done at UCSF on 738 patients. They identified 144 who had completed both germline testing and tumor molecular profiling. Among the 134 patients without actionable germline mutations, they identified another 31 patients with a potentially actionable somatic mutation. 60% of these actionable alterations involve genes associated with the HR and DDR pathways. The authors' conclusions were that pancreatic ductal adenocarcinoma, a tumor molecular profiling after germline testing, detection of potential actionable alterations by 5-fold and should be recommended for most patients. This is another abstract that is important. This is a randomized phase 2 study of modified FOLFIRINOX versus gem nab-paclitaxel in combination therapy for locally advanced pancreatic cancer. So this was a randomized phase 2 study performed in Japan. 126 patients were enrolled in 29 Japanese institutions. And the primary endpoint of the study was first-year overall survival. The primary endpoint demonstrated that in the cohort of patients who received gem-nab-paclitaxel, the first-year overall survival was superior than patients who received modified FOLFIRINOX, but modified FOLFIRINOX achieved a longer survival in 2-year overall survival, and median overall survival was also higher for FOLFIRINOX versus the nab paclitaxel and gemcitabine study. So the critique of the study is that there's a bit of contradictory results between the first-year overall survival and the second-year overall survival. But my feeling is that I think that we really need to look at the more advanced, longer overall survival in order to evaluate the real weight of these two options. And this also leads me to another important study, and that was a retrospective analysis trying to compare modified FOLFIRINOX versus gem plus nab-paclitaxel in patients with advanced pancreatic cancer. So in the study, this was a Canadian group. They tried to evaluate a target trial using linked data from a variety of databases. Patients had to have locally advanced or metastatic disease. 298 patients were identified. 70 had received FOLFIRINOX strategy, and 147 had received nab-paclitaxel gemcitabine strategy. In the study, the adjusted median survival for FOLFIRINOX was 8.2 months versus 4.8 months for gemcitabine nab-paclitaxel, and first-year survival and second-year survival were also superior for the FOLFIRINOX arm versus the gem nab-paclitaxel arm. So the authors' conclusions that finding from this real-world trial emulation suggested an overall survival with FOLFIRINOX regimen over gem nab-paclitaxel protocol. And another, for me, an important abstract is how social determinants on health evaluate and change survival of patients with pancreatic cancer. So we know that disparities in pancreatic cancer are documented, but it's unclear how this reflects on diagnosis or throughout treatment. So this was a retrospective analysis done in a national cancer database in which over 230,000 patients were included. In univariate analysis, multivariate analysis, and univariate Cox analysis, higher education, higher income, and insurance all decreased the odds of stage 4 pancreatic cancer. However, Black race was associated with the higher odds of stage 4 pancreatic cancer. In the multivariate Cox analysis, only higher income and having insurance were associated with improved overall survival. The authors' conclusions were that perhaps expanding insurance coverage could be an effective public health intervention to improve early diagnosis and survival rates between different groups of patients. And my last abstract I would like to share with you is the impact of early palliative care treatment on the quality of life of patients with advanced pancreatic cancer. This was called the Imperative Study. So we know that early palliative care alongside standard oncological treatment can improve quality of life and sometimes even survival in other cancer types. However, the impact on quality of life and symptom burden in advanced pancreatic cancer is not known. This is a prospective case crossover study with patients with advanced pancreatic cancer in which received early palliative care from a subspecialist of palliative care physician and an advanced practice nurse plus oncological care. Quality of life assessments were preferred by questionnaires. And in the study, early palliative care resulted in improved quality of life in patients with pancreatic cancer receiving chemotherapy and those with a BMI of over 25, and improved quality of life and symptom burden in patients with metastases. The authors' conclusions that were providing palliative care alongside the standard oncological care early in the patient's projection of treatment can prove to have a clinically meaningful improvement on their lives. And that is my last abstract. And thank you very much for listening to me.
Yeah, thank you so much, Talia, for giving us this very comprehensive overview about the most recent abstracts. And I think there is a lot to discuss. And now I'm happy to announce, as I was mentioning previously, Professor Eric van Kooczen, a full professor at the division and the division head of digestive oncology at the University of Leuven in Belgium. And we know him from many presentation abstracts, and he's very active in ESMO and an awardee of the ESMO Award in 2019 and many other international highly recognized awards. And our second discussant today is Professor Changhoon YOO from the Asian Medical Center, University of Arts and College of Medicine in Seoul, South Korea. He is a medical oncologist. He is specialized in GI cancer, pancreatic cancer especially, and also cholangiocarcinoma. And I'm very happy that we have you today here in the team, and we can discuss the clinical implementation of these abstracts of the ASCO 2021 meeting into the clinical practice. Let me probably first start with the last abstract, Talia, you were presenting, the Imperative Study. Palliative care is so important. We know it that we should should enroll and also include palliative care to the patients when they are still on treatment in stage 4 of pancreatic cancer. However, I would be very much interested in how you handle this, because patients have different expectations. Sometimes when they see the medical oncologist, they want to hear from you treatment options and treatment advices, and sometimes it might be a little bit tricky then to talk in parallel about palliative care and palliative medicine. And so, Talia, I would be very interested to know from you, how do you have it, how is the setting in your center?
So it's a very nice question, actually, Gerald. I think it's really the tool of our trade. Specifically in the study, it was also for patients with that were on chemotherapy. And I think it's just being very honest with our patients about expectations. And what I found with my patients is that often it's actually easier for them because they reflect with me on treatment and hope and maybe experimental treatments and new options. But then they also have the other avenue to discuss quality of life matters and end of life matters. And I actually find that it's helpful. We're very lucky. In our setup, we have a very strong palliative care unit, and actually physically They're right next door to me. They are they're the offices next door to my offices, our offices, and so I get a very good, I get lots of help from my patient. It's really hands-on, and it's interesting. Sometimes I would speak to like the nurse practitioner from the palliative care unit, just to me, the patient said this and this to me, and I'm like, what? I can't believe that patient had such insight, because with me he was, in another role. So I actually think that the duality of having two different roles and maybe reflecting different options from our patients actually makes it easier for them. And I don't think it makes it more confusing. I think it actually makes it easier for them.
Okay, see, Eric, should we include our colleagues from the palliative care unit into the MDT? So at the time of diagnosis that they see already or get the case presented at the MDTs? Or do you think that's too early?
We don't do that. We have, when we see a new patient, for instance, here in pancreatic cancer, we discuss, of course, at the MDT in locally advanced situations, the different treatment options, or in a local tumor. We don't go for all patients in metastatic or at clearly metastatic disease at the MDT and in this setting. And then on top of that, regarding your question, no, we don't have the palliative care physicians at the MDT being present, because palliative care and the team of palliative care, that's important to have them bedside also with the patients, and the patients are not at the MDT. So once we have a patient who starts with chemotherapy, the nurse practitioner or specialist nurse, as we call that, they are present, they come to the patient, the psychologists see them, the nurses see them, and then if needed, we go for, we start opening the discussion on palliation, but then it's important to understand and to talk clearly with the patient, because the patient thinks, sees the oncologist or the one who treats him as being in the driver position. And then I open the discussion always on symptom control, and in case it doesn't go well, on palliation in this setting, but not for the first consultation. No, they are not involved right now, neither at the first consultation, but the whole team is involved in this setting when the patient starts with the treatment.
Excellent. So, Dr. Yoo, can you tell me your experience? How do you have palliative care involved in the treatment concept of your patients in your center in South Korea?
I see. In our center, fortunately, we have one medical oncologist who focused on the palliative care only. So she is in charge of the whole palliative care team, including the anesthesiology and the psychiatrist, and also for the rehabilitation medicine doctors. So we do not send every pancreatic cancer patient to that MDT for the palliative care. For in some time, particularly at the time of the tumor progression, is the patient requiring some discussion about the palliative care. We send our patient to the palliative care team, and during management is to me it is very helpful to focus on the management of the tumor itself by myself, and so it's very happy to focus on the about this treatment option in my clinic and the palliative care things in the palliative care MDT team. So it is very lucky to have those kind of the special team. But this problem is that the team is very small, and we do not. There's no such enough capacity to include all patients in that team.
Thank you so much. Let's switch a little bit the topics. Let's go to the neoadjuvant setting. I think it's a hot topic in pancreatic cancer. Talia, you summarized two interesting abstracts, the Biobank data on the one hand, and then the GSOC data from the locally advanced setting. So what do we have learned from this? Should every patient be treated with a neoadjuvant concept? And what's the role of radiotherapy? If you look on the PREOPANC data, is it the neoadjuvant chemo, is it sufficient, or what is your approach outside of clinical studies? Let me start, Liz, first with Talia again.
Yeah, I think as being a medical oncologist, I've always felt very strongly about the neoadjuvant approach, and I think that now we have quite strong evidence-based data to justify us thinking about obviously the borderline resectable I'm putting aside, because we've had evidence-based medicine and it's been in the guidelines to use the neoadjuvant approach in those patients for quite a while already. For the resectable patients, we didn't really have strong evidence-based medicine. My gut feeling was that it should be offered, and I thought it would be like that in the future. And I think that we're coming close to that. For me, we're coming close to that area that I think we should definitely start discussing neoadjuvant for all our patients, including those that are resectable. In regard to which protocol, I think that still is, we don't have enough data. I mean, we have comparative cross-trial data, but we don't have, one-to-one data. But I think that we can all assume that even if GEM as a single agent is working with radiation, then, the FOLFIRINOX protocol, with or without, is also going to be, substantial for that.
So you would rather consider a most active treatment approach? Isn't that what you mean? So most active in terms of chemo combinations plus minus radiotherapy? Or do you think
we're actually going to have we're going to decide on a policy for our institution. We're going to have a discussion between our radiation specialist oncologists and surgeons for the hepatobiliary team. And we're going to obviously go through this data in more detail, and we're going to make a policy for our institution. But I think that it's going to go in that direction.
Okay, I see. So, Eric, in the PREOPANC trial, the patients in the experimental arm, they had also not only, in addition, radiotherapy, but also in some more chemotherapy, not only neoadjuvant, but if you add up the perioperative chemotherapy, there was more chemo than in the control arm. Do you think the chemo is doing the job and the perioperative chemo is it, or do you think the radiotherapy has a role in the neoadjuvant setting? Your personal opinion.
Difficult question. I think we can say that there are today two standard options. It's going clearly towards a neoadjuvant treatment in the future. In the clearly resectable patients, surgery followed by FOLFIRINOX for 6 months is for sure today still an option also. However, we see more and more data, PREOPANC and strategic studies, and also there was an Asian study last year presented that preoperative in a randomized setting may have a benefit. Remember that at the initial presentation, however, of the PREOPANC study, the study was formally speaking negative in this situation. Regarding what is the best strategy in the neoadjuvant setting, that's not clear. The big weakness of the PREOPANC study is that also they compare surgery with the weak chemotherapy, which is not a standard treatment anymore today. And the control arm was surgery followed by gemcitabine. I do realize that in the experimental arm, the chemotherapy was also gemcitabine in this situation. But that's for me a big weakness, also with the fact also that at the initial presentation, the initial primary endpoints did not meet statistically significance in this setting. I think that for me, what would be the future is, of course, to look at in resectable patients, pancreatic cancer still remains in very experienced surgical centers a metastatic disease. And all the failures that you see are at distance. So the best treatment in this situation, if you want really to have an impact on the outcome, is systemic treatment, I do think. And so the future, but we need a bit more evidence, and in the future it will be, and we are moving towards a direction that's clear, preoperative chemo, with the best chemo that we do have being FOLFIRINOX as another option, gemcitabine, nab-paclitaxel. We, in our situation, based on only the PREOPANC studies, we will not add radiotherapy in this situation right now. I think we need a bit more evidence in this.
Okay, thank you so much. How is it in South Korea? Do you consider in a neoadjuvant setting for front-up resectable patients or for patients borderline resectable radiotherapy or chemoradiation? Is this part of the concept you have outside of clinical studies, Dr. Yoo?
Yes. Yeah, thank you for the great question. It is a very tough question. There is in Korea there is one randomized clinical trial comparing neoadjuvant chemoradiotherapy versus the upfront surgery for borderline resectable cancer. That study was positive, but that study and also and this PREOPANC study was performed in the prior modified FOLFIRINOX the era. So it is quite confusing to whether we should change the practice according to the results of these trials. So in our inner discussion is we felt that the chemoradiation, the outcomes in the PREOPANC and in Korea and other Korean study is not enough to change the practice currently, because we have for adjuvant modified FOLFIRINOX, and our center is very experienced center for the pancreatic surgery. So we still do the surgery followed by the adjuvant modified FOLFIRINOX for the resectable patients. If patient have some high risk of the recurrence, such as the high CA19-9 level, some kind of that kind of the risk factors is induced made us to the use of the neoadjuvant modified FOLFIRINOX, even patients are the resectable. So in the future, we may need some more than clinical randomized clinical trial using the modified FOLFIRINOX, neoadjuvant modified FOLFIRINOX in the resectable pancreatic cancer to change our practice in Korea. Yeah.
Okay, let me switch a little bit to the locally advanced, so the non-resectable locally advanced pancreatic cancer. Do you want to shortly comment what is your preferred chemo regimen in, let's say, rather young, fit patients, so ECOG 0, 60 years old? What would you choose, Dr. Yoo, in a patient? Is it more FOLFIRINOX, or do you, in your center, use more nab-paclitaxel, gemcitabine? I know that's the $1 million question nobody really can answer, but I think we would like to learn how other centers are treating, and so we can learn from you as the experts here today, what would be your approach for a fit, let's say, rather young patient with 60 years locally advanced or non-resectables?
Although there is no, so in the Japanese clinical trial, the FOLFIRINOX and the nab-paclitaxel show comparable efficacy outcomes, but I believe that the modified FOLFIRINOX have a lot of the cumulative evidence for the locally advanced disease, and also the previous studies show that the response rate is higher than the nab-paclitaxel. So I prefer to use modified FOLFIRINOX for patients, for medically fit patients with the locally advanced disease. Yeah.
Okay. In Israel, in your center, Talia?
Yeah, I think you said it so nicely previously right now. I think that, as you said, the cumulative overall evidence is just kind of tips more for the favor of the FOLFIRINOX, and the long-term evidence, and even in the Japanese study. And it's also interesting. I mean, that study that I discussed, the emulation clinical trial from Canada, that showed that's not in local disease, it was in metastatic disease, but still it showed quite a big difference. I know that it's an emulation study and it's not a randomized phase 3 study, but this is the data we have till now. We have more evidence-based data than that. So I think that when you also look at that, that is directly reflecting on a neoadjuvant approach. It can still reflect on, if you put the two protocols one against the other, I think maybe the substantial kind of accumulating evidence in favor of FOLFIRINOX, that would be our favorable protocol in this situation.
Okay, how is it in Leuven, Eric?
Quite similar to what we've heard in Korea and in Israel, and I guess, I don't know, in Austria, but yeah, we give most patients FOLFIRINOX also in this situation, at least if they are fit. However, the recent data showed that Gem/nab-paclitaxel is also a clear option for these patients. But looking at, as was said rightly, the cumulative data, and also a lot from cross-trial comparisons, we prefer, we do usually FOLFIRINOX.
Okay. So then we have heard an abstract which I think attracted some attention with the masitinib plus gemcitabine in those patients with locally advanced disease suffering from pain. I mean, the study itself was strong. However, this was a subgroup analysis. Do you think it's practice changing, Talia? So you go tomorrow to your patients suffering from pain, and you go to the doc oncologist next door and take the masitinib for your patient.
The study design was a little bit confusing, and the study results themselves are a little bit confusing. And I think that that doesn't allow me to make this practice changing with the data. And I think that I personally, I wouldn't give gemcitabine to a locally advanced pancreatic cancer patient in a good performance status. So there's too many things that accumulate for me not make this a favorable current treatment option until we get more data. But I think that it is a venue that needs to be further evaluated. It may be a cleaner study, that we can get more reasonable and informative results, and that we would know how to continue.
So, Dr. Yoo, would you also like to see stronger data on masitinib in the locally advanced setting? Do you think it's worth going for it, or do you think it's just I don't know, statistical coincidence that in this subgroup there was some effect of masitinib?
Yes, I'm totally agree with the opinion of the Talia. As far as I understand, that positive data is the post-hoc subgroup data, is that they might be caused by the statistical fluke, not by the real drug efficacy. So we need some more data based on the clear clinical study design and using the modern chemotherapy regimen as a partner in the future. So it is not enough to recommend to our patient yet.
So also, Eric, I want to ask you, of course, what's your opinion about masitinib in pancreatic cancer?
A bit skeptical. It's interesting, of course, if we see such subgroups, but again, I would be more convinced if masitinib would be added up onto more what is a standard approach, or compared, if we could compare gemcitabine plus masitinib versus a combination chemotherapy in this group of patients. And if in this situation we would see a benefit, then it would be practice changing. But today, because of the modest impact, median survival benefit of less than 2 months in a subgroup of locally advanced disease, I'm quite reluctant. And it's interesting, of course, and it's good that Talia selected that for presentation, just for the sake of discussion, but it's not practice changing right now.
Okay. So Talia, as we have you here for molecular profiling, that's your field of expertise besides many others, but so what would you recommend? What should we going to test right now? Should we, at every patient metastatic setting, have a molecular profile, including NRG1 testing and a germline mutation testing, just in case we will get more data in the near future? Or what is your approach in your center, and what would you recommend outside of an academic center?
My approach in the academic center, and this is what we've been doing for many years, is that we firstly, in pancreatic cancer, we strongly advised to do genetic familial testing. So that would cover the Lynch and the BRCA genes. Especially in a country like ours where we have our founder mutations, this can be done in a timely manner and we can get very robust results very quickly. Patients in Israel are normally very well informed, and before I can even finish the explanation about doing genomic hereditary testing, they're already asking me about one of the commercial studies. So I say to them, I think that the best practice and also, the best cost-effective practice would be, let's get your genetic results in 2-3 weeks. And if they're negative, then I think it does make sense to try and do genomic analysis of the tumor, but the option to find a potentially actionable mutation is quite low. So in the study done from USCSF, it depends how you define a potentially actionable alteration. It's a very broad term, and I think they gave it a very broad definition. I don't have all the data yet from that, but I think it was quite a broad term. And but it does, going ahead, like even if you think about cost effectiveness, I'm jumping now to non-small cell lung cancer, but if you have more than already 3 or 4 alterations, it actually makes sense to do bulk testing because of just the way, cost effectiveness to do 1 or 2 genes somatic, yes, or, do already a panel of 300 or so forth. So I know that in our country, I think if you have more than 3 or 4 known alterations that can inform treatment and are FDA approved, then that already makes sense to go to a panel test of 200, 300 genes. And I think we're going there in pancreatic cancer because we have the MSI, we have the NTRK, and we're going to have soon probably the NRG1. So, we're going to be there soon.
Dr. Yoo, what is your approach in your center? You test every patient for germline mutation before you start treatment. During you the patients in first line or not at all?
Yes, genetic testing in Korea is very strictly regulated by the Korean law. So we do. So fortunately, we do. I don't know why, but this Korean government support all the targeted sequencing, including 200 to 300 for every advanced cancers. So every patient just pay $500 for the targeted sequencing. So usually in my practice, every patient asks for the NGS, but it's sometimes, even though I say that the chances of the finding of the is actionable target in pancreatic cancer is very low in our Korean population, but the patients ask about the test, but it's in germline mutation test is the problem by Korean law. Is in Korea is for patients with a strong family history and the patient strong family history of the breast cancer, the ovarian cancer is allowed to do the germline test for the BRCA. It's not allowed for the sporadic pancreatic cancer patients. So we do have some suggestion to our government to change that law. But so because of that is we do not usually do the germline test for the BRCA mutation. So we do the somatic the mutation test for the using the NGS, and if the patient harbor the BRCA mutations, then we recommend the germline mutation test. Like kind of the backwardly, yeah. That is the Korean situation.
Eric, do you do NGS in every patient, and do you test germline mutations in every patient?
But it's a moving target and a moving decision, and with progressing insights. But today, yes, in virtually all pancreatic cancer patients, we do germline testing for BRCA. In the past, and I'm speaking of less than a year ago, the issue was to report in a timely way, but now we have made service agreements with the Center of Human Genetics so that we have the reporting within a few weeks in the setting. So since then, and we can have it reimbursed also, that's not an issue anymore. Since then, we do germline testing in virtually all patients for BRCA testing. NGS, no, not in all patients. We look, we do a stepwise approach. We look at somatic HRD, so BRCA, CHEK2, PALP, ATM, because we have also trials ongoing with PARP inhibitors in this setting. We look at MSI, but that's not very frequent. But just an hour before this meeting, I saw a patient with pancreatic cancer with a sporadic MSI to pancreatic cancer patients in this situation. And then we look at KRAS. As you know, the majority of patients have a KRAS mutation. In those looking further and doing NGS, in our experience, that's not very helpful. These NTRK fusions, these NRG fusions, that's all in RAS wild-type patients. The occasional BRAF or other alteration, that's all in the KRAS wild-type. So if we look at, in practice, we look at MSI, HRD, and KRAS, and if KRAS is wild type, then we may go further doing an NGS in this patient. So that's a stepwise approach. But if you would ask me that question, I don't know, 6 months from now or 12 months from now, it's likely that my answer may not be the same. It's progression in our knowledge and thinking and approach.
Thank you so much. We have time for a short comment because I think nobody can really give the answer to my next question. Why are pancreatic tumors so immunocold tumors? So we have seen the abstract with the combination of nivolumab and CD40 antibody. We have seen other combinations, and there was not even, I would say, a sign of any effect. Sometimes it was even worse if you compare if you look at the last trial with nivolumab and CD40. So is there any explanation? Are we looking the wrong direction, or just we haven't found the key to make those tumors hot? Talia, may I ask you for a short answer or a difficult question?
Yeah, so there's actually, I don't agree that they're completely cold tumors. There's nice preclinical work coming also from Ringsert lab and others that do show T-cell infiltration into these tumors. I agree with you that from a clinical trial point of view, we still regard these tumors as quite cold tumors, and we haven't managed to define the key to open the immune signal in these patients. But there actually is, and it's becoming more and more evidence that these tumors do actually have T-cell infiltration. So that's my short answer.
Okay, thank you. It seems to be, at least it's a promising answer, that at the end of the day we will manage it to overcome this endogenous resistance. Eric?
Yeah, I agree with Talia in that sense that with the actual approaches and the actual immuno-oncology approaches, indeed, they seem to be cold, and we haven't found a clue. I do think that we will be successful at the long term, but yeah, I don't have a good answer to you. Otherwise, we would have to go together to Stockholm to get a Nobel Prize if I would have the clear answer to your question, Gerald. But yeah, I do think that research is evolving, and you see that fundamental research is evolving, and you see and you feel that there will be probably completely new mechanism of actions, new ways of interfering, probably combinations, so that we can hopefully be successful in that, in this direction. And you see first preclinical data mainly and mechanistic data. I know that's not the end of the story, but that probably help us to understand a bit better so that we can approach and target with the new agents and not with the classic checkpoint inhibitors, PD antibodies, CTLA-4 antibodies. That's not the situation. So we will have to elucidate more the mechanism of action, and then clearly also find new immuno-oncology classes of agents in this setting. And as an oncologist, you have to be optimistic, and I'm optimistic that in longer term we will find ways to go towards.
Yeah, Changhoon, a short comment from your side.
I agree with your opinion. As the current PD1 PD-L1 CTLA-4 inhibitor shows very disappointing results in the pancreatic cancer. Although the in the preclinical study, pancreatic cancer seem to be immunogenic, and some have some immune infiltration. So I believe that we still miss the right target for the immunogenic target for the pancreatic cancer therapy. So as the FOLFIRINOX, some kind of the very aggressive therapy beat the long-standing standard gemcitabine monotherapy. So I do believe in the future more as well targeted, more aggressive immunotherapy such as CAR T-cell or something like that may show some signal of the immunotherapy benefit in pancreatic cancer. Yeah.
Thank you so much. I want to thank you as the experts. You're the top-end experts in the field of pancreatic cancer, and it was a big pleasure and honor to have you here in this discussion round here. And special thanks to you, Talia, Golan, for giving us this very comprehensive, interesting overview of the most recent abstracts. So I want to thank you and wish you a good rest of the day. Stay safe, and I hope we have you on board soon. Bye-bye.